اوكي، انتوا كده شايفين السكرين صح؟
ايوه يا فندم، شايفين السكرين كويس.
تمام اوكي. اول كنت عايز اقول حاجتين. اول حاجه بالنسبه للتسجيل، حد كان سالني اذا كان ممكن يسجل. لا، ما عندناش مشكله، اي حد عايز يسجل يسجل. وانا شخصيا كده كده هسجل المحاضره، تبقى عندي لو حد فيكم احتاجها. واللي عايز يسجلها برضو اوكي من عنده، مفيش مشكله. خلاص، دي اول حاجه. تاني حاجه، انا بس هستاذنكم، احنا هنتكلم تقريبا المحاضره تبقى كلها بالانجليزي علشان احنا في معانا ناس اعتقد ان هم مش عربي. فهنخلي المحاضرة لو حد مش فاهم حاجة قوي ومحتاجين نشرحها له بالعربي هتبقى استثناء يعني. بس هتبقى المحاضرة كلها بالإنجليزي إن شاء الله. أوكي.
تمام يا فندم معاك.
بسم الله الرحمن الرحيم. احنا إن شاء الله النهاردة يعني هناخد زي ريفيو كده. هنحاول إن احنا نكفر كل الموضوع من أوله لآخره بشكل مختصر شوية، بس نبقى جبنا كله من أطرافه مرة واحدة، لأن هو الواحد حتى لما يبقى سامع يعني تفاصيل كتيرة في بعض الحاجات بيبقى عايز ياخد صورة كاملة للموضوع. This is the agenda that we will discuss today. إن شاء الله. The sessions will be divided into four sessions. The first one will be an introduction, and we will discuss the physical background of multi-slice CT, the requirements of good quality cardiac CT study, CT anatomy of the heart and coronary arteries, and the pathology of coronary artery disease. Then we will have a small break. Then we'll start the second session, and we will discuss the techniques of CT coronary angiography, the patient selection and patient preparation and pre-test considerations, assessment of coronary artery disease and so of coronary artery calcification, coronary calcium score meaning, contrast protocols for coronary angiography, modes of acquisition in cardiac CT, and finally the image display in cases of coronary CT. The third session will be the interpretation of coronary CT angiography study. We will discuss first the artifacts of coronary artifacts in coronary CT angiography, and will proceed to interpretation of congenital coronary anomalies, ectasia and stenotic lesions, cabbage and stent cases. And finally, we will have a short resume about the aortic root. We will discuss the CT anatomy and the pre-TAVI assessment in cases of CT for the aortic root يعني. Okay. This is the map. We will the topics that we will discuss today إن شاء الله. The first topic is the physical background of multi-slice CT. Multi-slice CT, the physical background of CT is similar to that of the X-ray. The CT and X-ray have the same the same physical principle, which is the photon attenuations. In case of X-ray, we have a source of photons, which is the X-ray tube, and the photons are attenuated while passing through the object, and finally presented in the film or detectors. According to the degree of attenuation, we have the image. Photons, which are photons that passes through bones, are markedly attenuated, while those passing in the web spaces are partly attenuated, and in the space here, the photons are not attenuated. And so we have degrees of gray according to the energy of the photon passed from the organ. The CT has similar principle for imaging, but the X-ray is a projectional 2D image, while the CT we have a cross section. In order to image the cross section, in the CT machine, we have, like the X-ray, we have a source of photons and have detectors behind the patient. The photons should pass through the patient and show different degrees of attenuation to be detected on the detectors under the patient. In order to have a cross section, we have to locate every point in the section, and so the organ should be imaged or pictured from different angles. In order to localize a certain opaque structure, we should have multiple views of the multiple angles for this object to localize the site of the object. As if you have one side like the X-ray, this will be a projectional image, and we will have here an opacity, and we couldn't localize the site of the opacity if it is anterior or posterior. But if we have images from all sides, then we can localize the site of opacity and take an axial images like this, and we can localize the areas of high density and areas of low density. And from the axial image, we can reconstruct the coronal and sagittal images. And so the physical principle of computed tomography is attenuation of the photon, and the images should be projected from all sides from the 360 degrees to create the axial image. Computed tomography started as sequential images, scan and scan without volume acquisition. Later on, the helical CT was developed with helical acquisition and volume images. The slip ring technique helped us to develop this volume acquisition by using the slip ring technique, and so the detectors are not connected to cables and can rotate around the patient for the whole cycle without stop. The development after the helical CT was the multi-slice CT. The idea of the multi-slice CT was instead to have a single row of detector and consequently single image in the tube rotation. We have multiple rows of detectors, and we can image multiple and we can acquire multiple sections in the same tube rotation. We started by 4 detectors, and the condition developed now up to a very large number of detectors. The idea of the multi-slice CT was we can acquire multiple rows of detectors in the same tube rotation, and the tube rotation was more rapid as compared to the single machines, single row of detectors machines. In the past, in the single scanners, the tube rotation time was 1 second, and so we could acquire one axial image in the second. While with development of the multi-slice CT, the rows of detectors had increased to 4, and the tube rotation time have been reduced because reduced to half a second. And so in the same second, in the previous scanners that we imaged one axial image, in the recent multi-slice scanners or in the developed multi-slice scanners, we had acquired 8 images in the same tube rotation. There was also development of reconstruction algorithms to acquire the image by half rotation instead of full rotation. And so in the 1 second, the tube rotate around the patient 2 times. Each time it acquire 4 images, and it needs half rotation to create the image instead of full rotation. And so there was a large number of images created in the same time. And so this allowed us to for rapid allowed us for rapid acquisition, and this allowed us to image the coronary arteries, which was impossible before the development of multi-slice CT. The adding factors is the addition of ECG gating and advanced reconstruction techniques. And here the CT coronary angiography was in the field of imaging in the CT. The benefits of multi-slice CT is the improved temporal and spatial resolution and the scanning time. And so we can acquire large number of images in a very short time, and we don't need to increase the slice thickness or create gaps or prolong the time for acquisition. We can acquire multiple acquisitions in a very short time without gapping and without increase the slice thickness. And so we could proceed to perform CT coronary angiography in this with the multi-slice CT. CT angiography of the coronary arteries is a challenging technique because we have multiple anatomical and pathological factors that interfere with proper evaluation of the coronary arteries. The anatomical factors include the small size of the coronary arteries, as they range between 2 or 4 millimeter in average diameter. Their courses are tortuous and run in different planes, and they show continuous movement with respiration and with cardiac motions. In addition, the proximity of coronary veins to the coronary arteries that interfere with proper interpretation of the coronary artery of the coronary angiography when the study is delayed. The pathological factor that challenged us in evaluation of the CT angiography of the coronary arteries is the dense calcification also. The dense calcifications make the interpretation more difficult because of the blooming artifacts. In order to, CT scanning of the coronary arteries is an operator-dependent process. Okay, in order to have a good quality report, we have to have first a good quality examination, and so we have to concentrate on the patient selection and preparation to have and the and to to pay the or to delineate the requirements for coronary angiography from the scanner and from the operator. Requirements of good quality cardiac CT regarding the scanner, we have to have the best spatial resolution and temporal resolution, the shortest scanning time. We have to do ECG gating and breath holding while scanning. Spatial resolution, by definition, is the shortest distance to discriminate between two separate points. Okay, it denotes the level of details in an image and depend on the slice thickness, which is related to the detector width. The spatial resolution is usually measured in the in plane, which is the axial plane, as it usually reduced slightly with the reconstructions. Here are 3 images using different scanners. This is a single row detector, dual row detectors, and quad. As you see, the resolution have been improved greatly with the multi-slice CT because we have used the minimum slice thickness, while in the single slice detectors we used 1 centimeter detector. Here we used 0.5. Spatial resolution is expressed in line pairs composed of a dark line and an adjacent light line. For example, a resolution of 10 lines per millimeter means 5 dark lines alternating with 5 light lines, or 5 line pairs per millimeter. The more lines we can differentiate in the millimeter, the best the spatial resolution. The temporal resolution, we have also to have the best temporal resolution to have a good quality CT coronary angiography. The temporal resolution is the time needed to acquire a single image. The time needed to acquire a single image, and it is related to the tube rotation time. The temporal resolutions equal the tube rotation time divided by 2, because it is the time needed to acquire an image. It is related to the cardiac motion artifact. The better the temporal resolution, the less the cardiac motion artifacts. And it is related to the patient heart rate. Machines with good temporal resolution allows us to have examination in patients with high heart rates. While the older machines or machines with limited temporal resolution, in these cases, we have to reduce the heart rate to below 70 to get a good quality examination. How to improve the temporal resolution? To reduce the time of acquisition, we have to either to fasten the tube rotation time, and the fastest tube rotation time now available is the 270, and the temporal resolution is 135 milliseconds. The other option is to have dual source CT images, CT scanners, because in the dual source we need to irradiate 1/4 of the cycle, not the half of the cycle. You can imagine this tube, the red tube, will move to this side, and the green one will take the side of the red one, and so each of them moved 1/4 of the cycle, resulting in irradiation of half the cycle. And so we need the temporal resolution, the time needed for acquisition is the tube rotation time divided by 4, not by 2. And this improves greatly the temporal resolution. And so in cases, in scanners with dual source, we can perform heart rate higher than 70 beats per minute. Still, the CT is behind the conventional angiography in imaging of the coronary arteries regarding the spatial, temporal, and contrast resolution. The spatial resolution of the CT have improved to 0.5 millimeter in average, while in the conventional angiography it is 0.16 millimeter. The temporal resolution is about 75 for dual source scanners. It is 8 milliseconds in cases of conventional angiography, and the contrast resolution is much more better in angiography because it is an intracoronary injection of contrast, while here in the CT we inject intravenously, and so the images of the invasive coronary angiography is still higher in spatial, temporal, and contrast resolution when compared to the images of CT angiography. And that's why the conventional angiography is the gold standard technique for evaluation of coronary artery lesions. In addition, it allows for intervention. The third requirement, we have discussed the spatial resolution. We have to use the best spatial resolution with least slice thickness. We have to use the best temporal resolution with the fastest tube rotation or dual source CT. The third requirement is the shortest scanning time. We need to have a short scanning time to allow acquisition of images free of respiratory motion. Scanning time is the entire time needed for the scan from start of the scanning to the end of the scan. And this is different from the temporal resolution. Temporal resolution is the time needed to have an axial image, while the scanning time is the time needed to have to perform the study from from the study to end. It is related to the number of detectors and not the tube rotation time, and it has a advantage for patient that cannot withhold their breath for a long time, because the better the shorter the scanning time, the less the respiratory motion artifacts. They also are efficient for cases of AF with irregular heart rate. The wide, sorry, we can with scanners of short scanning time, we can acquire at single cardiac beat, and so we can perform the examination even with cases of AF. The fourth requirement for having a good quality CT is the ECG gating. The ECG gating allows to correlate the time of image of acquisition of a slice to the corresponding time in the cardiac cycle. In case the ECG gating could be could be expressed in percentage from the RR interval, like 50% of the RR interval, or 70 or 40%, or expressed in absolute number from the R, like in this case 400 milliseconds before the R or after the previous R. In cases of regular heart rate, we usually use the percentage of the RR interval, and also we can use the absolute time. While in cases of AF or irregular heart rate, it's better to reconstruct using the absolute time from the R, because the percentage will be different from cycle to another cycle. We have two types of ECG gating, the prospective and retrospective ECG gating. Retrospective ECG gating, in this case, we irradiate the heart, or the acquisition is continuous throughout the cardiac cycle from the R to the R, and we use certain point of the cardiac cycle for reconstruction of the images. This part of the cardiac cycle could be the diastolic or systolic or everywhere, because we are imaging the heart in the whole cardiac cycle. While in the prospective, the images are taken at a certain point of the cardiac cycle, not throughout the cardiac cycle. And so if you perform the exam at the diastolic phase of cardiac cycle, we don't have systolic images, and vice versa. If we take the examination at the systolic window, we will not have images at the diastolic window. The retrospective ECG gating have the advantage of acquiring images at different phases of the cardiac cycle, and this allows us for evaluation of the cardiac function, because we have images in systole and diastole, and allows us to have the coronary arteries at different phases. Sometimes the diastolic images are affected by cardiac motion artifacts, and in this case you can refer to the systolic images. While in the prospective acquisition, we have either systolic or diastolic images, and we cannot perform cardiac function. And if the images, say, for example, the diastolic images are affected by cardiac motion artifact, we have no opportunity to create images at the systolic phase. But on the other hand, retrospective gives the patient a large amount of radiation, while the prospective, there is a significant reduction by about 40% of radiation. And so we have an important advantage here in the retrospective imaging is that we have images throughout the cardiac cycle, and we have an important advantage here in the prospective that we have reduced significantly the dose the dose of radiation. During the early days of CT coronary angiography, using the retrospective, the dose radiation was high enough to limit the spread of the examination. It was around 30 millisieverts, and this is a large number. With prospective images, in the early days, the radiation dose have been reduced to around 15 millisieverts. Okay, how to solve this problem? Here we have the advantage of having images throughout the cardiac cycle, and here we have the advantage of reducing the radiation dose. To improve the conditions with the retrospective imaging, dose modulation was introduced. The dose modulation implied that the radiation, in spite of the radiation, is on throughout the cardiac cycle from the R to R, but the full dose is applied to the area of the cardiac cycle that usually used for reconstruction of images, between 30 or 40% of the RR interval up to 80%. This includes the mid and late systoles and the mid and late diastole. While outside the 40% and 80% of the cardiac cycle, the dose was significantly reduced. And here we have the advantage of collecting images at the systole and diastole, actually throughout the cardiac cycle, and so we can perform cardiac function analysis. On the same time, we have reduced the radiation dose by about 30% from the original dose in cases performed with respective ECG gating without dose modulation. On the other hand, the retrospective images, which was initially performed at a single point of the RR interval, the condition was dealt by increasing the width of the acquisition by forming padding. In this case, the retrospective with padding, we have a wide or severely wide window of imaging from 40 to 80% of the cardiac cycle, but in this case, outside this window, there is no acquisition. And in this case, we cannot perform cardiac function, but we can have images at the systolic and diastolic phases of the cardiac cycle, so we can interpret the coronary arteries at the systole and diastole. The retrospective imaging with padding, a widening of the window, this also allowed for reduction of the dose as compared to the retrospective, but not the as compared to the retrospective imaging and not the prospective. In cases of prospective imaging, the heart rate should be extremely regular because the acquisition occurs over multiple cycles. The acquisition here is in the form of scan and scan. Then we have to scan, in this case, 1/4 of the heart, and then stop for a while the table movements occur, then scan the second fourth of the heart, then stop for a while the table is moving, and so on. In cases of multi-slide scanners using 64 channels, the heart is imaged over 4 acquisitions using 8 cycles. It is mandatory to have a very regular heart rate, otherwise the stepladder artifacts will appear between the slabs acquired. The condition is better with the scanners covering 8 centimeter per rotation, like the scanners of 256 channels, and we have only one interposition line here in the middle of the heart, and we need 3 sequential cycles with extreme regularity. In cases with single acquisition, cases with 320 detectors, we have the heart, all the heart acquired in a single cardiac beat, and this allows us to have a good quality examination free of cardiac motion artifacts. But on the other hand, this acquisition, the patient receive a very small amount of radiation, and so the images are slightly blurred by the low radiation. In some cases, the acquisition is repeated 2 or 3 times, and the images are used, all of them together, to create the final image. And the final requirement, in addition to the best spatial resolution and best temporal resolution, shortest scanning time, and ECG gating, is the breath holding. Breath holding is mandatory in cases of CT coronary angiography to avoid respiratory motion artifacts. As we know, we acquire multiple axial images and reconstruct from them the images of the coronary arteries. If the images are not opposite each side, we'll have a coronary image that is not interpretable. And so we have to look for the images of the chest with long window to evaluate the patient for to evaluate the study for respiratory motions, if any. We have to explain to the patient before the study to stop breathing and not to strain. And sometimes we need to train the patient to perform the breath holding, especially when if the time needed for breath holding is relatively long. The respiratory motion artifacts in the lung appears like this. We have here the white structures here are the vessels containing the contrast, and the black one are the air within the lung. In this image, we can see that there is no well-defined outline of the vessels, and so the respiratory motions here can degrade the image of coronary arteries. The respiratory motions can be appreciated also in the coronal plane when looking to the diaphragm, imaged twice like this. This means the massive respiratory motion during scanning. Okay, we have discussed the physical principles of CT and the requirements for good quality CT. Now we are going to have a look on the anatomy of the heart and coronary arteries. Coronary arteries are composed of 2 systems: the left coronary system and the right coronary system. The left coronary system is performed by the left main trunk, which is a short trunk arising from the left coronary sinus. The coronary left main trunk gives no branches. It divides into the left anterior descending and the left circumflex arteries. The left anterior descending artery runs at the anterior interventricular groove between the right ventricle and the left ventricle, supplying 2 types of branches: the diagonal arteries that descend on the anterior surface of the left ventricle, supplying it, and the septal perforators that supply the upper part of the interventricular septum. The left circumflex artery runs in the left AV canal between the left atrium and the left ventricle, supplying multiple branches on the lateral wall of the left ventricle. These branches are named obtuse marginal branches and numerated or numbered 1 and 2, obtuse OM1, OM2, OM3, and so on. Sometimes we have an early branch here from the left circumflex artery named as high lateral branch. The circumflex artery continues to reach the lateral wall of the left ventricle, then the inferior surface of the left ventricle, where it ends by supplying the posterolateral branches. And so we have the left anterior descending artery supplying the diagonal branches and septal perforators. The left circumflex artery supplying the obtuse marginal branches sometimes supplies the high lateral and ends by giving the posterolateral branch at the inferior surface of the left ventricle. Sometimes the left main trunk, instead of bifurcating into LED and LCX, it trifurcates into the LED, ramus intermedius, and LCX. The ramus artery runs at the anterolateral wall of the left ventricle and supply it, taking the role of the first diagonal or first OM artery. The second coronary system is the right coronary artery, being formed by a lower branch in most of cases. The right coronary artery have this C shape, arises from the right coronary sinus and runs a horizontal course. Then its middle third runs a vertical course. Then the final third component runs on the inferior surface of the heart. The right coronary artery runs at the right AV groove, supplying multiple right ventricular branches. The first two branches are the conus and the sinoatrial branch in most of cases, and it ends at the inferior surface of the heart. At this point, the crux between the right ventricle and right atrium, by supplying the posterior descending artery and the posterolateral artery. The posterior descending artery runs at the inferior surface of the heart at the interventricular groove opposite to the left anterior descending artery and usually reaches the apex, while the posterolateral branch of the right coronary artery shares in supplying the inferior surface of the left ventricle with the posterolateral branch of the left circumflex artery. And so the inferior surface of the left ventricle is supplied by the posterolateral branch of the circumflex artery and the posterolateral branch of the dominant right coronary artery. The interventricular septum is supplied from septal perforators of the left anterior descending artery. Its upper part, its cranial part, is supplied by the septal perforators of the left anterior descending artery, while its caudal part is supplied by the posterior descending artery branch of the right coronary artery. The anterior wall is supplied by the left anterior descending artery and its diagonal branches. The lateral wall is supplied by the circumflex artery and its obtuse marginal branches. The coronary arteries are divided into segments. The right coronary artery, the proximal segment of the right coronary artery is segment number 1. Its middle segment is segment number 2, and its inferior segment, its inferior or distal segment is the segment number 3. And finally, the posterior descending artery is considered as segment number 4. The left main trunk is segment number 5. The proximal, mid, and distal left anterior descending segments are segments number 6, 7, and 8. The proximal segment is demarcated from the middle segment by the origin of the first large septal perforator and first large diagonal branch. The lateral circumflex artery, its proximal segment is assigned as number 11, the first OM number 12, the mid or distal part of the left circumflex artery is assigned for 13, and the second OM branch for 14. In some cases, in some textbooks consider the PDA branch of the dominant LCX number 15 and the BL terminal branch of the dominant RCA number 16 and the ramus intermedius number 17 and the BL branch of the BL terminal branch of the circumflex artery is segment number 18. Coronary dominance. Okay, these images are for the inferior surface of the heart. In this image with right dominant in 85% of cases, the right coronary artery is dominant, and this means that the right coronary artery runs to reach the inferior surface of the heart between the right atrium and right ventricle, and at this point, the crux of the heart by dividing into PDA, posterior descending artery, and posterolateral branches. This occur in about 85% of cases. While in about 8% of cases, the left coronary artery is the dominant artery. The left circumflex continue at the inferior surface of the heart, supplying the posterolateral branches that will supply the inferior surface of the left ventricle, and ends by giving the posterior descending artery, which will run at the interventricular groove at the inferior surface of the heart to supply the caudal part of the interventricular septum. And in this case, the left ventricle is entirely supplied by the branches of the left coronary artery, and the right coronary artery does not share in the blood supply of the left ventricle, and so it has no importance regarding the myocardial ischemia. In this case, the left anterior descending and the PDA, the left anterior descending are the septal perforators of the left anterior descending, and the PDA of the left circumflex supply the interventricular septum. The posterolateral branches of the left circumflex supply the inferior surface. The OM branches of the left circumflex supplies the lateral wall, and the diagonal branches of the LED supplies the anterior wall. The LED itself also supplies the apex. In about 7% of cases, the circulation is co-dominant. And this means that the right coronary artery ends at the crux by giving a small PDA, and the left circumflex artery also ends at the crux by giving a small PDA. And sometimes the LED wrap around the apex, supplying part of the inferior surface, the caudal part of the interventricular septum. The co-dominant circulation occurs in about 7% of cases. We should know the anatomy of the coronary veins as well, as sometimes the acquisition is delayed, and the coronary veins could appear filled with contrast and should be discriminated from the coronary arteries. The coronary veins, this is the great coronary vein running concomitant with the left anterior descending artery, and then runs at the left AV groove with the circumflex artery to end here in this structure, which is the coronary sinus that collect the coronary venous return from all coronaries, and ends in the right coronary, the right atrium. This is the middle coronary vein running concomitant with the posterior descending artery, and also ends in the coronary sinus. And finally, this is the small cardiac vein running with the right coronary artery and end in the coronary sinus. This is a lateral coronary vein, and its importance. It is and sometimes the pacemaker wires are inserted in this vein, lateral vein of lateral coronary vein. Okay, CT anatomy of the coronary arteries. I will show this case. This is a normal case of CT coronary angiography, and we will revise the CT coronary, the anatomy of the coronary arteries here. Do you see the screen?
Okay, yes.
Okay. These are the images of CT coronary angiography. The axial image, and this is the coronal image, and this is the sagittal image, and this is the 3D image. At this high level, you know this is the ascending aorta, and this is the descending aorta. This is the mean pulmonary artery, and this is the right pulmonary and left pulmonary branches. This is the superior vena cava with the contrast washed. And here are the pulmonary veins. At a lower level, here we have the right atrium, the left atrium, the right ventricular outflow tract, and the left ventricle. And here is the left atrium, right ventricle, left ventricle. This is the interventricular septum, and this is the apex. That is the lateral wall of the left ventricle. And there is the interatrial septum. This is the aortic root. And here are the pulmonary veins, two on the right side and two on the left side. And this is the left atrial appendage. Okay. These are the three sinuses of the valva in the aortic root. This is the right coronary sinus, and this is the left coronary sinus, and this is the non-coronary sinus. The right coronary sinus faces anteriorly toward the sternum, while the left coronary sinus at the left posterolateral aspect and the non-coronary sinus at the right posterolateral aspect. The left main trunk arises from the left coronary sinus as a short trunk with no branches, divides into the left anterior descending artery and the left circumflex artery. The left anterior descending artery supplies the first and second diagonals and continue here. And this is the third diagonal branch. It reaches the apex of the heart and wrap around the apex for a short distance. Okay. These small branches are the septal perforators. You can imagine this. More appreciated as the coronal image is here. Okay. And these are the two large diagonal branches. And here is a third diagonal artery. In the coronal image, this is the left coronary sinus, and this is the left main trunk, a short trunk that bifurcates into this is the circumflex, and this is the LAD. Here is the ascending aorta, the pulmonary trunk. This is part of the left atrial appendage. This is the um, aortic valve, and this is the left ventricle. Here is the right atrium. Okay, the left anterior descending artery is this artery. Okay, and this is a diagonal branch. The left anterior descending artery reaches down to the level of the apex. And this is the left circumflex artery. Runs at the left AV groove between the left atrium and left ventricle. Here is the left atrium and left atrial appendage, and here is the left ventricle, and this is the mitral valve. This is the left circumflex artery. And this large branch is an OM artery. This small one is also an OM branch. First OM, second OM artery, and finally the third OM artery, which is a large branch. In the axial images, this is the left circumflex artery supplying small OM. This is the first OM, second OM, and finally the third OM artery. This is the right coronary artery. This is the ostium of the RCA, and here is the right coronary sinus. The right coronary artery runs at the right AV groove between the right atrium and the right ventricle to reach the inferior, supplying right ventricular branches like this, and reaches the inferior surface of the heart, where it ends by supplying a posterior descending artery, which is this, the posterior descending artery, and posterolateral branches, which are the continuation of the right coronary artery. This is the right coronary sinus, and this is the end of the inferior vena cava. In the sagittal images, This is the right coronary artery. Here we have the sternum anteriorly and the vertebral column posteriorly. The right coronary artery arises from the right coronary sinus anteriorly, and this is the vertical middle part of the right coronary artery in the inferior surface. It ends by supplying the posterolateral branch and the posterior descending artery. This is the posterior descending, and this is the posterolateral branch. This is the left main trunk, arises from the left coronary sinus. Here is the left coronary sinus, and this is the non-coronary sinus. When we go more anterior, this is the right coronary sinus. Okay, the left main trunk is a short trunk that bifurcates into left anterior descending and left circumflex artery. This is the left anterior descending artery. You can see it. It extends down to the apex and supplies diagonal branches. This is a diagonal branch, and this is the circumflex artery, ends as a long OM artery branch. Okay, this is the CT anatomy of the coronary arteries. And by the way, these are the right and left internal mammary arteries. This is the sternum anteriorly. These are the ribs and the vertebral column posteriorly. This is the angiographic anatomy of the coronary arteries. The coronary arteries are arranged in two planes. One is the atrioventricular plane, and one the interventricular, parallel to the interventricular septum, and one parallel to the atrioventricular plane. This image is right anterior. This image is right anterior oblique. Displays the left anterior descending artery, the septal perforators, and the diagonal are foreshortened here. This is the posterior descending artery. Okay, and the right coronary and left circumflex arteries are foreshortened. They appear better in the left anterior oblique plane, where the right coronary artery appears like letter C, supplying the right ventricular branches and ends at the crux here by giving the posterior descending, which appears foreshortened in the left anterior oblique, and the posterolateral branch. The left circumflex artery appears like inverted C with marginal branches and ends as the posterolateral branch. These are angiographic images showing the left main trunk. This is the tip of the catheter, and this is the left main trunk. The left main trunk divides into the left anterior descending artery and the left circumflex. The left circumflex supplies an OM branch, large OM branch, and ends by bifurcation and ends by giving a posterolateral branch, which is this branch. The left anterior descending artery supplies the diagonal branches and ends at the apex here. This is the left anterior descending artery, and these are diagonal branches. And these small branches arising from the inferior surface of the left anterior descending artery are the septal perforators. This is the right coronary artery. This is the proximal segment, mid segment, and distal segment of the right coronary artery. It ends by bifurcation into the posterior descending artery, which appears here bifurcating, and the left and the posterolateral branch, which is the terminal branch of this dominant right coronary artery. As you see here, we can appreciate multiple septal perforators and small branches of the diagonal arteries, and even small third or fourth order branches of the OM. While in the CT, we can only appreciate the large diameter branches. We cannot see the septal perforators very well. Barely we can see a large septal perforator or two septal perforators, while here in the conventional imaging, we can see a large number of septal perforators and diagonal branches. Do you know why?
Because conventional angio give do subtraction for only arterial tree, not. Is this right?
No, it's not related to the subtraction. It's related to the spatial resolution, because the
Yes.
spatial resolution of the angiography is much better than the spatial resolution of the
Higher.
CT.
Yes.
And so the angiography gives much more details compared to the CT. Not because of the subtraction, because in the CT you have more details and you can see the artery even without subtraction of the ventricular cavity or the septum or whatever. But the limitation is in the spatial resolution and not in the subtraction.
Yes. Yes. CT high in contrast, but low resolution, special resolution. The reverse is angio. High in special resolution, low contrast. I think.
The CT has lower spatial resolution than the catheter, the conventional angiography. Do you remember the numbers? The spatial resolution of the CT is around 0.5 millimeter. And this number is related to the width of detectors and related to the number of the width of detectors. While in the X-ray or conventional angiography, the spatial resolution is 0.16, which is much lesser than 0.5. And so we have spatial resolution in the X-ray much better than CT. The temporal resolution is also much better in catheter compared to the CT. If you remember, when we talk about the temporal resolution of CT, the best temporal resolution ever for the dual source CT was 75 milliseconds, while the temporal resolution for the angiography was
Little
anyone
sensitive.
can remember the number?
10%.
8 milliseconds. 8 milliseconds. And the contrast resolution of the catheter is better than CT. Why? Because in the catheter we inject intracoronary, while in the CT we inject intravenous. And so definitely the concentration of contrast will be much, much better in conventional angiography than CT.
Okay, thank you.
Okay. This is the slide. The spatial resolution in the CT is lower than the spatial resolution of angiography. Temporal resolution of the CT at its best is 75, while the temporal resolution of angiography was 8 milliseconds. The contrast resolution of this in the catheter is much better because we inject intracoronary, while in the CT we inject intravenously. Okay. Continuing with the anatomy of the heart, we have the cardiac planes. The cardiac planes are the axial, coronal, and sagittal of the heart. As you know, the heart is present in the chest in an oblique position. And so the axial, coronal, and sagittal of the body does not correlate with the axial, coronal, sagittal of the heart. And so we can create planes to delimit the cardiac chambers caused as the cardiac planes. I will return here to show you. Okay, this plane is the axial plane for the chest, but not the axial plane for the heart. Okay, we can do this oblique. Okay, better this. Okay. And here we have the cardiac planes. Okay. This is called the short axis plane of the heart, where the left ventricle is appears as cross section, appears as a circle like this. Okay. Here is the anterior wall of the left ventricle, and this is the septum, and this is the inferior wall, and this is the lateral wall of the left ventricle. Okay. This plane can be moved toward the base of the heart. This is the base of the heart, and this is the mitral valve. This is the mitral valve at the base of the heart. The heart, this is the apex of the left ventricle, and this is the base of the left ventricle. When we move from the base to the apex, here we have this image with anterior wall, septal wall, inferior wall, and lateral wall. This is the basal segments, and here are the mid segments. These are the two papillary muscles. This is the anterior wall, medial wall, inferior wall, and lateral wall. And when you go more apically, these are the apical segments. Also, these are the anterior wall and septal, inferior, and lateral walls. And finally, this is the apex itself. This is called as the two-chamber view. The two-chamber view where we have each atrium with the corresponding ventricle. At this level, we have the left atrium and left ventricle. When we move like this, we will have the right ventricle and right atrium. Right ventricle and right atrium, but here they are not opacified. This is the left atrium, and this is the mitral valve, and here is the left ventricle. As you see, this is the anterior wall, and this is the inferior wall, and this is the apex. While this plane is called the four-chamber view, where we can see the four chambers, the right ventricle, the left ventricle, the right atrium, and the left atrium. Here we can appreciate the septal wall and lateral wall, and there is the apex. And so in this plane, the two-chamber view, we can see the anterior and inferior walls. In the four-chamber view, we can see the septal and lateral walls, and in two cases, we can see the apex. In this plane, we can see from basal to mid to apical, we can see the anterior wall, the septal wall, the inferior wall, and the lateral wall. But we cannot see the apex at this plane, the short axis, okay? The cardiac planes, this is the two-chamber, four-chamber, and short axis. And the short axis, there are the basal cuts and apical cuts. The segments of the myocardium are 17 segments, okay? They are represented as follows. The large circle outside represents the short axis view in the basal segments. The smaller circle inside are the segments at the represented in the short axis view in the mid segments. And these are the apical segments, and finally this is the apex. And so this is the anterior, and this is the septal, this is the lateral, and this is inferior. And so on the basal segments, we have basal anterior, basal anteroseptal, and basal infroseptal, basal inferior, basal infrolateral, and basal anterolateral. These six segments are seen at the short axis view at the basal cuts. When we get inner, these are these are six segments also identified at the mid level. خلاص. This is the anterior, mid anteroseptal, and mid infroseptal, mid inferior, and this mid infrolateral and mid anterolateral. When we go toward the basal segment, they are four only: apical, septal, inferior, and lateral.
دكتور الصوت بعد إذنك. segment of
Okay. These are the 17 segments of the myocardium. The segments out in the outer circle represent the segments in the short axis view at the basal, at the base of the heart, the base of the left ventricle. And these segments are the basal anterior, basal anteroseptal, and basal infroseptal, basal inferior, basal infralateral, and basal anterolateral. The mid segments are similar in distribution, but at the mid level of the left ventricle, and the apical segments are only four: anterior, septal, inferior, and apical, and finally the apex of the heart. They are colored, tagged according to their arterial supply. The segments tagged by the yellow are supplied from the left anterior descending. Those tagged by red are supplied by the right coronary arteries in case of the right coronary dominance, and the segments tagged by blue are the segments supplied by the left circumflex artery. As you know, the septal, anteroseptal segments are supplied from the septal perforators of the LAD. The anterior are supplied from the LAD and its diagonal branches. The anterolateral are supplied from the branches of the OM branches of the circumflex, and these segments are supplied from the posterolateral branch of the left circumflex artery. The mid-septal, mid-infroseptal, and basal infroseptal are supplied. The caudal part of the interventricular septum segments are supplied by the branches of the posterior descending artery, and the inferior surface of the heart is supplied by the posterolateral branch of the right coronary artery when the right coronary is dominant. And so, when each segment of these are affected by perfusion defect or hypokinesia or whatever, we can imagine that the cause of ischemia is coming from which artery and which branch. Okay, we can go to the pathology of coronary artery disease. Myocardial ischemia, by definition, is a reduced tissue blood supply or imbalance between the blood supply and oxygen requirement. These definitions are applied for the hypoxia. Ischemia means, in addition to the reduced blood supply or imbalance between the blood supply and oxygen requirement, additionally, it implies the reduced removal of metabolites due to failure of appropriate level of perfusion. Coronary insufficiency is caused by multiple etiologies. The most important one is the atherosclerotic or the atherosclerotic coronary artery disease. Atherosclerosis is formed by atheroma. It implies subintimal deposition of cholesterol-laden plaques and inflammatory cells. This is a cross-section of the artery. This appears in purple is the intima, and this is the media. The circle outside the intima is the media, and the outside is the adventitia, tunica adventitia. Here is an atheroma deposited subintimal, and the intima is elevated, and this atheroma is present between the intima and the media. The plaque or the atheroma is composed of a lipid core and inflammatory cells, mainly the macrophages. It usually has a fibrous cap and shows new intima, new angiogenesis. Here, the new blood supply, small new blood supply supplying this atheroma. The atheroma could be complicated by calcification, deposition of calcium in the atheroma, or presence of necrotic tissue or hemorrhage. Hemorrhage from the new angiogenesis and necrosis and calcium deposition. These are the factors of the atheroma and its complications. Here we have we have to understand two important points: the positive remodeling and the pathogenesis of ectasia. Let us first proceed with the myocardial ischemia. The mechanism of myocardial ischemia and infarction in cases of atheroma is either chronic expansion of the plaques that can lead to development of flow-limiting coronary stenosis. This means that the atheroma start to increase in size and encroaches more and more on the lumen. This leads to a reduction of the lumen caliber, and this will lead to ischemia. The other way to produce ischemia is the rupture of the plaque. The plaque could be not a large size; it could be medium or small, even size. But when its fibrous cap is interrupted, there is exposure of its thrombogenic components to the blood, and this leads to thrombosis. And this will lead to a marked reduction of blood flow at the level of the plaque, even when the plaque is not severe. The plaque could cause 30 or 40 or 50% stenosis, but it can develop thrombosis on top due to disruption of its fibrous cap, and this will lead to acute ischemia. This process is chronic, gradual increase in size of the atheroma and gradual encroachment upon the lumen. This is a gradual process and usually associated with collateral and could be less dangerous than this scenario where the cap is interrupted and the contents of the atheroma is exposed to the lumen with consequent thrombosis encroaching significantly upon the lumen. Regarding the positive remodeling and the mechanism of ectasia. Positive remodeling means that the plaque, beside its extent to encroach on the lumen of the artery, it also compresses the media and adventitia. And so the whole size of the artery from wall to wall will increase at the site of the atheroma. Like this image, you can see the plaque here. The plaque encroaches upon the lumen, and the lumen here is narrowed compared to the reference proximal to it. And in the same time, the plaque encroaches upon the fat outside the artery, and so the whole width of the artery have been increased. This is called positive remodeling. And the positive remodeling has multiple applications. One of the most important applications is that when you measure the degree of stenosis at this point, you have to compare the diameter here or area here to a reference area proximal to the site of stenosis. And you are not allowed to measure at the site of lesion because of the positive remodeling. The positive remodeling will markedly increase the reference and will give false impression of high degree of stenosis. The second point is the pathogenesis of ectasia. Ectasia means dilatation of the coronary artery, and the pathogenesis of ectasia is not clear. But it's considered a type of atherosclerosis where the atheromatous plaques are not deposited subintimal, but instead the atheromatous plaques are deposited in the media. And as you know, the media is formed of fibrils interacting with each other. When the sorry?
Okay, yes.
Okay, معلش. When the deposition of atheromas in the media, this will interfere with proper tone or contraction of the muscle fibers in the media, and this will lead to dilatation of the artery, and this will lead to ectasia. The second pathology occurs is dilatation of the artery is associated with slow flow and stagnation, and this will promote thrombosis at the wall. And so the ectasia is an atherosclerotic process, but the deposition of fat is in the media, not in the subintimal space. And the mechanism of ischemia is slow flow and thrombosis at the wall of the artery. Okay, other causes of coronary insufficiency or myocardial ischemia other than atherosclerosis is the syndrome X, which is a typical anginal chest pain with normal coronary angiography, and it's attributed to microvascular disease, not diagnosed by CT or conventional angiography. Coronary spasm, attacks of anginal chest pain with free interval, no ECG changes, and normal coronary angiography. Transmittal angina or variant angina, this is a chest pain at rest, maybe associated with ST segment elevation, and could present as a perfusion defect in the thallium study, and this could be attributed to prolonged coronary spasm, as in these cases there is no atherosclerotic changes in the coronary arteries. And finally, the coronary congenital anomalies also can produce myocardial ischemia in some cases, as we will see. The clinical presentation of myocardial ischemia is stable angina. This is number one and the most famous and important one. It's characterized by paroxysmal and usually recurrent attacks of typical chest pain. The typical chest pain is described here. The character is constricting, squeezing, or heaviness, or knife-like. It's usually transient, 15 seconds to 15 minutes, usually substernal, pericardial, or left side of the chest. Could be radiated to the base of the neck, jaw, or left arm, precipitated by physical effort or mental stress, and relieved by rest or nitrates. When there is paroxysmal and recurrent attacks of typical chest pain, this is considered as stable angina caused by reduced myocardial perfusion to a critical level, usually due to chronic stenosing coronary atherosclerosis, rendering the heart vulnerable for manifest ischemia whenever there is increased demands. Unstable angina, typical anginal pain that occur with progressively increasing frequency and prolonged duration, with precipitation by progressively less effort. Transmittal angina is anginal pain at rest due to coronary artery spasm, response to vasodilator as nitroglycerin and calcium channel blockers. Coronary ischemia could be presented also by myocardial infarction. Myocardial infarction is persistent. The clinical presentation is persistent and severe typical chest pain with long duration, more than 15 minutes, and not responding to rest or nitrates. Other presentations of myocardial ischemia could be chronic ischemic heart disease with chronic heart failure or sudden cardiac death. Okay.